So day shift, you come on, there should be a team lead or a charge nurse that walks the department and checks all of the trauma or emergency carts and make sure that they're still locked and they haven't been pilfered. So when they have been pilfered and an emergency happens, there's chaos, and then fingers start pointing. It's somebody else's fault, but it seems to never be the operating room's fault.
Rising above the buzz of ultrasonic cleaners and the clanking of stainless steel are the ideas and voices that are changing an industry. You're listening to the Beyond Clean podcast, the central nexus for the people, processes, and products that are improving our sterile processing world. Each week, we speak with frontline technicians, CEOs, engineers, and entrepreneurs with a common goal: to help you fight dirty, every instrument, every time. Whether you're tuning in for education or inspiration, we're glad you did. Now turn on those washers and turn up the volume. It's time to go beyond clean.
All right, Clean Freaks, welcome back to another episode of the Beyond Clean podcast. You're listening to Season 30, Tray Command. I'm your host, Bobby Parker, and joining me as co-host for the season is the wonderful Angela Benson. Angela, welcome back to the studio.
Thank you so much.
Absolutely. Well, today is going to be a fun conversation. We're talking emergency carts today. I think we titled the episode Break Glass in Case of Surgery. And I've spent a little bit of time with emergency carts, but to be honest, being on the sterile processing side of things, haven't seen a whole lot about the justification for why we need them. And I don't know, from SPD side, it always feels like they maybe have more than they need, or it can certainly get out of hand of having too many. I'm not sure what your experience with this topic's been like.
Well, top of mind is airway carts. So that's something that we service with a flexible endoscope. And so that is kind of the thing that I think of the most. We do have a little bit of, trauma or emergency lap carts that we have kind of set up as like a swap system. But I really think that it's the intubation carts are very vital, where you have your CMAX and things like that. So that's really for sterile processing kind of, I think that we see that a little bit more when we're handling those endoscopes.
Yeah, for sure. Well, what I've always wanted to do around this topic is to grab somebody from the OR by the lapels, sit them down, and just have a frank conversation with them about emergency carts. Why do we have them? Why do we need so many? What's the best way to keep these restocked for the sake of patient safety? And so that's what we're going to try to do today, bringing in a guest who's got some experience in the OR and in sterile processing to try to sort through the particulars of how to do emergency carts. Well, should be a really fun conversation. We'll be right back with David Taylor after this short break.
From the studios of Healthcare HQ, you're listening to Beyond Clean, the global voice of sterile processing.
And joining us now in studio is David Taylor, founder and president of Resolute Advisory Group. David functions as an independent consultant and offering interim leadership for both sterile processing and OR spaces. And David, it's good to have you back on the podcast. Welcome back to the show.
It's great to be here. Thank you.
Before we dive into the topic at hand today, David, why don't we give folks an opportunity to get to know you a little bit? Could you introduce yourself and tell us a little bit about your background and what you've been doing in the sterile processing world these days?
Sure. Well, David Taylor, I have a master's degree in nursing, Lean Six Sigma certification. I've been in the operating room and sterile processing space for several decades. Don't want to admit my age at this point, but I started my career probably mid-'80s. And back in the day, we were both OR and SPD. There weren't two departments. We basically did surgery all day, and at the end of our day, we put our instruments back together, sterilized them, and got them ready for the next day.
So whenever you go into an OR these days, do you have to resist the urge to say, back when I was learning as a scrub tech, we did our own instruments?
I've used that line a couple times with people when they are very caustic with one another with the relationships, right? Because it's really one team. It doesn't matter what the departments are. We have one mission to take care of patients. And because SPD is such an integral part of surgical services and procedural areas, it makes better sense to be a partner than an enemy. And that line has helped a little bit. When people look at me as a registered nurse, they're like, well, what do you know about SPD? Well, I put instruments together for several decades, probably longer than you've been alive. And, I think I have some knowledge of the space.
For sure. And sometimes referencing back to either those days or that model where the OR helps out can help give some context for the point of use treatment conversation. The game has changed in some respects with how quick we're expecting turnovers to take place. And gosh, how many total joints can we have one surgeon get through as he's zipping back and forth between rooms? And there is a real objection to be made of, we just don't have the time to do the point of use treatment that you're asking for. Sometimes drawing on those experiences of managing your own instruments and kind of that old school mindset of not handing a bloody instrument back to the surgeon, like always wiping, always having that basin at the ready. I think we could do for some of that old school mentality in the OR from time to time, just to make sure we're taking care of our instruments well. But that's not the topic of today's topic, David. We brought you in. Today we want to talk a little bit about managing doctor carts and emergency carts. And as you know, that at least from an SPD perspective, that can get out of hand as we're trying to be prepared for every possible scenario. And we have all these nooks and crannies where we're hiding instruments away. But there's also some necessity to it and some good from it. So I thought, David, you'd be a great one to talk to on this topic, having kind of lived in both worlds, like as a recipient of emergency carts and a benefactor of it, and also somebody putting those together. So if you don't mind, to get us started here, why don't you walk us through some definitions? Give us that high-level overview of what we mean when we say emergency carts for the OR.
Well, as I've traveled the country helping organizations build their ORs or their sterile processing spaces, I think that definition changes, especially for your listening audience. It depends on where you're at within the country and kind of what your roles and responsibilities are for that organization. What comes to mind kind of quickly is when you're in a larger facility, level 1 trauma center, these emergency carts can be, trauma cart for orthopedics, trauma cart for general surgery, trauma cart for neuro. But they can also translate into crash carts or hemorrhage carts for, say, mother-baby, right? So there's all kinds of definitions, I think, for the emergency cart world that sterile processing or central sterile is responsible for.
So related to the OR then, because I do want to touch on crash carts a little bit as well, because you're right, there are a lot of sterile processing departments that are setting up crash carts, and yeah, there's some pros and cons to that. But specific to the operating room, what are some of the more common ones that you've seen in facilities that are almost just a must-have that really do their part in saving the day when you've got an emergency?
I think the first thing that comes to mind is a level 1 trauma center, but I don't want to discount those critical access hospitals, right? A level 1 trauma center has 24-hour operations. So you have somebody not just in the operating room, but you have somebody in sterile processing 24/7. Whereas a critical access hospital may only work kind of daylight hours. Everybody goes home and they're on call. That would include your SPD department. So if there's an emergency, which do happen, right, you have to stabilize your patients in these rural spaces before you can then transport them to a higher level of care. So the premise would kind of be the same, right? So level 1, you got somebody crashing through the ER. They don't even have time to stabilize them. They're crashing through the OR doors and you're doing surgery. Does your organization have time to pick particular items, whether they're sterile or non-sterile, to support that patient's care and get it up to the operating room? There's very few, in my experience, SPDs that are co-located with the operating room. They either have to be pushed from that space, usually in the basement, to the OR through an elevator system, or they're put on an elevator that directly accesses the OR, similar to a dumbwaiter system. The critical access hospitals are usually smaller. They're down the hallway or in the basement. And again, you have to get the critical equipment to the operating room. So these emergency carts are pretty much a trauma cart or an emergency cart, however you label it, but it has the equipment and instrumentation as well as some of the soft goods, right? Drapes, etc., hand towels, you name it. And it's readily accessible, so you can pull that into the OR and start opening up and perform surgery within minutes.
With the sterile processing department portion of this, what challenges do you see them having with the emergency carts?
Well, it kind of goes back to Bobby's first comment about point of use cleaning, right? The OR says they don't have time to do something, so it doesn't get done, and it puts burdens on sterile processing. I would say the same argument applies to emergency carts or trauma carts. The operating room says that they're the most important and they're most busy and everybody should service them. So when they're in a crunch, they will pull from an emergency cart, which is verboten, right? We don't want to do that, but people do that because of human nature. And then you find yourselves with a trauma cart that doesn't have the equipment that should be there. And it's 3:00 in the morning and the patient's on the table.
I definitely know it comes back to then also that communication that we always talk about where, you have a trauma cart set up and maybe making sure you have enough backstock as well. I think that's key when you only have just enough to supply those individual carts and you don't know when they're going to grab and go. And if they're not communicating to the SPD that it needs to maybe be restocked, replenished, and we don't have enough that instrumentation, maybe we're down an instrument or so. But obviously that always comes back to communicating.
Yeah, it sure does. And, David, what you said about those instruments getting robbed out of convenience or maybe necessity for another procedure, and then that being left to sterile processing to somehow know that tray is missing, restock that tray, make sure that cart gets ready. That was a continual challenge in the facility that I was in of making sure that cart stayed together. Have you, or I guess you also, Angela, encountered or come up with any kind of solutions to help departments struggling with that very issue of how do we keep our procedure carts up and ready for a procedure?
The procedure carts themselves really fall to leadership. The leadership of SPD, the leadership of the operating room or the procedural space. It really comes down to leadership. What's interesting in nursing is when we're on, say, a med-surg floor, ICU floor, there's very specific things that the charge nurse and or the manager and or the director is responsible for. Part of that is counting the narcotics to make sure that the narcotics are what they should be, right? And there's nothing been pilfered. Same thing for crash carts. We check the crash cart to make sure it's working, right? And that it's locked and that it has everything in place. But what's funny about procedural spaces in the operating room is they fail to check their emergency carts on a shift basis. So day shift, you come on, there should be a team lead or a charge nurse that walks the department and checks all of the trauma or emergency carts and make sure that they're still locked and they haven't been pilfered. So when they have been pilfered and an emergency happens, there's chaos and then fingers start pointing at somebody else's fault, but it seems to never be the operating room's fault.
Sure. We had the benefit in our department of a sterile processing employee who spent most of their time in the OR. We called them the OR liaison. They were kind of the case cart guru. And so we had a natural person for that to fall to on day shift and then just had to supplement that on evening shift. But one of the challenges and burdens that we had at the time is all of our case carts didn't have a door lock on it. Like you could just grab it. In fact, it started out on open case carts. And so there was no way to secure those. And so we were going through with an inventory list and inventorying all the carts. And I tell you, one of the things that made the biggest difference for us on the emergency carts was getting just a handful of carts that had a latch on it that you could put like a crash cart lock on it. So then your inventory process is just, glance your eyes at that cart and see if that lock is still dangling there. And if it is, nobody's been inside the cart. And so I don't know, that helped us tremendously. But yeah, keeping those stocked is certainly one of the challenges. And then Angela, to your point on inventory levels, if you've got some high dollar equipment in there that maybe it's not going to be needed for a particular case, but gosh, it sure would be helpful if you could have another one of those to keep you from having to turn instruments over to service kind of the routine scheduled elective procedures. That would be really helpful. So there's an inventory question as well as we create all these specialty carts or doctor carts. And yeah, it certainly can be a challenge. David, when you gave us the definitions at the top and said that emergency carts can look like a lot of different things at different places, I want to throw into this category also just like the doctor carts, like so-and-so's plastics tray or anything like that, where the OR is requesting to keep a particular surgeon's instruments rather than in general inventory on like the cart that they use just for that doctor. Do you think that there's any wisdom or benefit to that, or should we try to steer clear of creating doctor carts if it's not going to be for an emergent procedure or trauma procedure or something like that?
So I'm on both sides of the fence there. So I don't like creating instrument sets that are specific to a certain surgeon, because that then lends itself that the instrument set is supposed to be put on hold until that surgeon arrives to the hospital. And what if I need those instruments set for a different surgeon or a different type of specialty, right? So creating individual surgeon sets, I'm opposed to, but doctor carts, I'm not necessarily opposed to. So for example, you mentioned orthopedics early in the podcast. I've created carts for those high volume surgeons, especially on a big orthopedic day, where all of my orthopedic instruments that would be used for those similar procedures could be rolled up to the operating room. And then the circulator and or the scrub can pull those instruments directly off of that cart as needed if additional instruments were necessary. Or I've created supply carts that were specific to a service line, say vascular, for example. You have all of the catheters and other items that they may need close at hand, and it can be rolled into the room or into a sterile core where that's easily accessible.
Yeah, that makes sense. I can understand the benefit. Sometimes living in sterile processing world, I don't have a background in the OR, David. And so it can be frustrating whenever what's being asked of you is creating yet another storage location for instruments, because that just multiplies the amount of time you have to go around searching for things and making sure everything is stocked where it's supposed to be. And how do you make sure that that tray ends up back on that cart? And yeah, lots of logistical considerations. But I can also imagine on the other end, to your point, particularly with supplies, it can be helpful to have that all in one spot where, on Thursdays when this doctor is here, we just bring this one cart in rather than going through the labor of gathering things from the four corners of from the OR and SPD to be able to do those procedures if it's really predictable like that. So I certainly can understand it.
Yeah. The other thing I would mention, and I don't think it's being talked enough in our industry, is the actual instrument usage during surgery. So there's a lot of research out there that's starting to unfold that surgeons are only using about 21% of the instruments in a particular set. So if you look at a major basic, for example, you probably have at least 100, but closer to maybe 150 instruments. And those touch points are not just SPD, right? It's the OR nurse and the tech counting those instruments, setting those instruments up. And then only 21% get used, right? So it's a lot of waste. So when we talk about inventories and creating carts and, creating emergency trauma carts, etc., research is showing us that only 21% of instruments are being used in a particular set. which leaves itself to a lot of touch points, whether it's the OR technician and nurse counting those instruments and setting them up, or whether it's SPD having to clean and or re-clean instruments that were never used during a procedure. So when we're talking specifically about emergency carts, trauma carts, doctor instrument sets, etc., we end up running out of volume, right? There's not enough instrument sets to support a surgical day. In that, we then have to create processes, and oftentimes we cut corners, and OR nurses or techs will pull from an emergency cart to support their surgical day, which then puts the hospital at risk, right? Or puts that patient at risk. So if we really started looking at surgeon-specific sets, which then limits how you can use that set, or if we look at what a hospital is actually doing for its surgical specialty set that they only have one of, could they really analyze how they're using that set, reduce the set only by 50%, which still gives the surgeon twice as many instruments as they need, and then create more volume or more instrument sets to support your surgical adventures, right?
Yeah, well, you're barking up the right tree for sure. And it can be daunting to try to do that, having walked through some of those optimization projects. And what really helps is having a champion who knows the instruments really well in the room. David, I imagine in your engagements, having lived in kind of both worlds and understanding sterile processing inventory, but also having been in the room for procedures, you could probably guide the OR to make some wise decisions about what maybe could come out of those trays, what needs to stay in. But yeah, if you don't have that kind of background, being able to find an advocate in the OR who gets the vision for, we want more inventory, we want more trays in the OR. And the way we're going to do that is, trimming the fat out of some of these others, recapturing those instruments and redeploying them in a different way. And that can be really transformative.
David, earlier in the show, we mentioned about crash carts, and I wanted to know your opinion on whether sterile processing is the right team for resetting those crash carts.
Is sterile processing the right place for managing the resupply of crash carts, hemorrhage carts, or whatever carts that end up in the department? And I really think that falls to the organizational philosophy. What is effective, right? So it really doesn't matter what SPD's role is and their responsibilities. Can it be effective? What I've often seen is it's not effective because it dilutes what SPD has to accomplish in a period of time. So the bigger question is, what is the responsibility for SPD or central sterile processing departments? Does the hospital place that responsibility as part of a materials management responsibility? Is it a responsibility that's just processing instrumentation? Do they have to pull cases for the day, meaning not just instrumentation, but the soft goods like the custom packs, hand towels, lap tapes, you name it? What is SPD's responsibility? When I've consulted and or done interim leadership, what I found is that the organizations that place all of these burdens, if you will, on sterile processing has more failures, meaning that there's more bioburden on instruments, or there's missing instruments or broken instruments, or the instruments are not maintained well because they're trying to service too many customers. A crash cart is very specific, and it has to have exact items, just like an instrument set. When a patient is coding in the emergency room or on the med-surg floor or wherever in the hospital, that crash cart has to be self-sustaining and functional. But if SPD is trying to put an instrument set together and the phone rings, and then that person gets distracted, answers the phone, then has to leave the area, go get a crash cart, deliver it, send it out to whoever's picking it up, then they have to get their mindset right when they get back to their workstation. So I find that if SPD or central sterile processing is going to have that responsibility, the organization itself has a responsibility to effectively staff those departments on those shifts so that they can manage that workload, because it's a completely different work responsibility than putting up instrument sets.
Absolutely. And I think when it gets to our end in sterile processing for the trays itself, utilizing priority tracking systems to flag those sets to state on our end, we're going ahead and making sure that those supplies are ready by us assembling those trays in a, stat kind of situation. And like you said, then it leads over to another area for responsibility to verify that gets back onto those carts.
Yeah, I've been in some departments where the sterile processing team is spending so much time not only resetting these trays, but also delivering them, going through all of the floors, spending significant FTEs on resetting the crash carts, which is fine. Somebody needs to spend the FTEs on it, but the question that often it comes back to is utilization of skills. The concept that gets talked about in healthcare is operating at top of license, right? We want our nurses doing nurse work, and that's why we have CNAs to be able to help support those nurses to be able to do some of the things where the nurses aren't operating at top of license. And so I wonder if it isn't wise to have sterile processing technicians, particularly certified sterile processing technicians, operating at top of license, doing surgical instrument preparation. And so whether or not that restocking of crash carts ends up in supply chain, or whether or not there's a sterile processing assistant role where they're not going through that certification process, gets added for restocking of case carts, I do think that there is probably some wisdom in at least considering how are we utilizing the resources of our sterile processing team, particularly if you're like the rest of us and certified, equipped sterile processing technicians are getting harder to come by, and we're struggling to get our instruments put together. But by golly, we are restocking all of those crash carts. You know what I mean? I don't know, David. Am I on track here? Do you think that there's any wisdom at least considering using some other resources to get those crash carts and sometimes emergency supply carts put together?
You're definitely on track with what you're saying. And I think what's important is understanding the value that sterile processing brings to an organization. Oftentimes, sterile processing is not considered a viable department because it's not revenue generating. But what administration and organizations fail to understand is without SPD, those revenue generating departments cannot make money because the delays in the operating room are so costly, or in those procedural spaces. Without SPD, it adds up very quickly, right? The deficit and what you could have earned versus what you really earn. Fast forward a little bit, you have sterile processing that reports to different entities. So if you have a sterile processing department that has a manager and it reports up through the OR, and most of the issues are coming from the OR, the SPD manager has no ability to really direct how the processes work because they report to a director in the OR. If SPD has a director, you have a more equal playing field between directors because it's more peer-to-peer, and you can have a relationship that has a conversation about the processes that are failing. Hence, if you report to materials management and materials management has no SPD experience, they're going to direct the SPD folks the way they know, which is materials management. So they're going to deal with supplies on a daily basis. I was recently at one client where literally they had to step away from their assembly table, putting instruments together for turnover cases in the OR, and had to go answer a doorbell to give supplies to a med-surg unit. So it really depends on how SPD is valued. Does administration understand its true roles and responsibilities? And can it function at a very high level if given the autonomy to do so. So we were talking a little bit about the responsibilities of the trauma carts, the crash carts, hemorrhage carts, whatever carts in specialty or kind that SPD is responsible for. There really comes an opportunity whenever an organization uses these carts for the OR to partner with SPD. As an OR leader, as a nurse, I understand SPD because I've worked in that department. When I have a nurse or a technician that decides that it's okay to take from a trauma cart or emergency cart, etc., we have a conversation. When an OR tech or scrub nurse doesn't do point of use cleaning, we have another conversation. If it continues, then I put those people in SPD to work for several days. And when they understand the burdens that they're creating in the operating room for sterile processing, then they have a better perspective. I kind of call it the walk a mile in my shoes perspective. So we have a team responsibility, even though we're different entities within an organization, we support one another. It's hard for an operating room to demand things from SPD when they're not doing their part, whether it's point of use cleaning, pillaging from a trauma or emergency cart, or creating specialty instrument sets that can only be used when a certain surgeon comes in. It really then puts a lot of burden or stress on the system.
Absolutely. And I have definitely in my own experience have seen the walk a mile in your shoes kind of situation. And it does build such a good team effort to have each side of it as well to see what the impact is. We have plenty more that we would love to talk about on this subject. And I've learned so much from you already. I thank you for joining us. And that's all we have for today. If anyone wants to reach out to you, they can find you on LinkedIn, I assume.
Yes.
Absolutely. All right. Thank you so much. We'll talk again soon.
Thank you both.
And that was David Taylor, president and founder of Resolute Advisory Group, sharing with us his thoughts on emergency carts, doctor carts, crash carts, and gosh, as I reflect on that episode, I think it was a helpful discussion and conversation around the use of those carts. The one theme that came up as really significant and important through the conversation is that of communication and collaboration. It can be tempting, particularly in an environment where sterile processing and the OR aren't one department, they're separate departments, for these two departments to look at this problem in an isolated, siloed way, and both in the interest of self-preservation are trying to get their way. Sterile processing would much prefer to have the inventory all close by, all in one spot, easier to manage, easier to keep par levels of. And the OR would probably much prefer to have the doctor carts and procedure carts and emergency carts set up in abundance so that whenever a case comes in, we can just grab this cart and we have it all ready to go. Both of those sets of priorities create some challenges, and there's not one right solution for your facility that can just be described and templated out. It has a lot to do with where the departments are located, what the case mix looks like at your facility. And so there's definitely an important conversation there to be had, but that's just it. How are you going to collaborate with your operating room to take a hard look at it? When was the last time that you went through your emergency carts and asked the question, like, when was the last time this was pulled and used? Has it been sitting here for 6 months and hasn't been needed? And also, which of these carts that we're keeping instruments on are for true emergencies and which are for convenience? How are these going to be stocked? Is it sterile processing's responsibility to round on these doctor carts to make sure that the plastics cart is all ready for Thursday, or is somebody in the OR doing that? And just communicating and evaluating those carts sensibly can really go a long way. I also hope it was helpful for you, the conversation around how to keep emergency carts stocked, because goodness, that can actually create more of a patient safety issue than less. If you have an emergency cart, but you don't know that it's been pilfered and you don't discover until they're opening it when the patient is already on the table, and you may have even been able to beat that time by just pulling a case cart when you found out that the patient was on their way in. So make sure that those are being evaluated and have a process that is clearly defined, easy to follow, not necessarily too burdensome. And I think those locking case carts are a great way to do that. Well, that's going to do it for all of the thoughts on emergency carts for this week. It's been a great season so far talking about tray logistics. We have a couple more conversations, particularly around case carts, coming up as well. So if you've been enjoying this season, I would encourage you to stay tuned every Monday morning. We've got more coming for you on this season 30 Tray Command. Until we talk to you again next week, I'll encourage you on behalf of Angela, myself, and the rest of the team over here at Beyond Clean, keep fighting dirty.
Thank you for listening to this week's episode of Beyond Clean. As a reminder, you can help support us by subscribing to Beyond Clean on your favorite podcast app, or by downloading the smartphone app on iPhone or Android. Simply search for Beyond Clean in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@beyondclean.net. We look forward to hearing from you.